is called torsades de pointes. The most common cause of QT prolongation is drug-induced, although other conditions, for example, ischemia and hypovolemia, and also it can be genetic abnormalities, may contribute. So, today we'll speak about the treatment of torsades de pointes, and we'll speak about the drugs of first choice in this type of arrhythmia. In addition to antiarrhythmics, many other drugs are known to prolong the QT interval. It can be prolongation of QT interval, can be the complication of myocardial infarction. If you remember, myocardial infarction is characterized by necrosis, and in the necrotic area and areas near the necrosis will be in the zone of ischemia, and in the ischemic zone it is the very comfortable conditions for generation of arrhythmias. So, and prolongation of QT interval on the EEG, such as macrolides, antibiotics and antipsychotics can prolong the QT interval, and as a result they can cause arrhythmia. Caution should be employed when combining drugs with additive effects on the QT interval or when giving QT prolonging antiarrhythmic agents with drugs known to inhibit their metabolism. So today we'll speak about antiarrhythmic drugs classification according to Vaughan-Williams classification. This classification is based on the predominant effects on the action potential. Although this classification is convenient, it has some limitations. But this classification is international, that's why, of course, you must know such classification of antiarrhythmic drugs. Many antiarrhythmic drugs have actions relating to more than one class or may have active metabolites with a different class of action, or may have an action that does not meet any formal classification. So today we'll speak about such drugs. So you can see that they can be put into the different groups of antiarrhythmic. So, but first of all, let's speak about physiology of action potential. On this slide, you can see the action potential of purkinje fibers, and so we'll speak about the zero phase. It is called rapid depolarization. It occurs when sodium channels open at the level of minus 60 millivolts, leading to rapid influx of sodium that shifts the cell membrane charge to plus 10, or like here, plus 20 millivolts. At peak depolarization, potassium channels open, leading to a slight decline in depolarization during phase 1, early repolarization. So, early repolarization. The duration of this phase determines fibrous conduction. The longer it is, I'm speaking about the zero phase. So, we are speaking about conduction. For example, if antiarrhythmic drugs increase duration of zero phase, we will speak about prolongation of conduction caused by such drugs. The longer the zero phase, the lower the conduction. as the example on this diagram of purkinje fibers. Longer conduction with the red line in the purkinje fibers. So second phase is called play 2. Calcium channels open at the level of minus 40 millivolt, and calcium influx via long-acting L-type calcium channels maintain the membrane potential during the second phase. So it is called second phase or play 2. So if we want to speak about mechanism of antiarrhythmic action of drugs, we then speak about their influence on the first or second phase. So these phases don't play major role in antiarrhythmic action. For us, it's more important to speak about zero phase, third phase, as now we'll speak, and later we'll speak about fourth phase, which is responsible for automaticity. But now we'll speak about the third phase. During third phase, it is called rapid repolarization. Calcium channels are closed. Calcium channels play a major role in the second phase, and potassium efflux returns the membrane potential to baseline. So it is outflux of potassium. So phase 3 determines duration of action potential and effective refractory period, ERP. So with the red line, you will see that it is the prolongation of the third phase, and such drugs as potassium channel blockers increase the duration of the third phase. So if we are speaking about antiarrhythmic action of such drugs, increased duration of third phase means that such drugs increase the duration of action potential, or such drugs increase the effective refractory period duration. So third phase also contributes to the antiarrhythmic action of antiarrhythmic drugs. Now let's speak about fourth phase of action potential. During the fourth phase, it is called slow diastolic depolarization, slow influx of sodium. So influx will show down ion currents into the cells. With decline of potassium efflux in the beginning of fourth phase, it is still the efflux of potassium, but it is more profound influx of sodium ions. So influx of sodium increases membrane potential up to minus 60 millivolts, and at this point phase 0 initiates. It is the threshold for initiation of the new action potential. So phase 4 determines automaticity. So for example, if we are speaking about antiarrhythmic drugs that inhibit sodium channels, such drugs will cause increased duration of action of zero phase. We are speaking about sodium channel blockers. And you see, sodium ions play the major role in the zero phase, so that's why sodium channel blockers prolong conduction of action potential. And also sodium ions play the major role during the fourth phase of action potential of purkinje fibers. So such drugs, inhibitors of sodium channels, also decrease automaticity, and according to this slide, of purkinje fibers. And if you take, for example, potassium channel blockers, you can see on the action potential that third phase is characterized by the efflux, outflux of potassiums. Those inhibitors of potassium channels prolong third phase. So we'll speak about the mechanism of antiarrhythmic action, that such drugs increase effective refractory period duration. So atrial node action potential. So the atrial node action potential differs from ventricular action potential in that phases first and second are not present. You see here, I put them together. Depolarization of the atrial node initiates with the slow leak of sodium across the cell membrane by the invert sodium channels. Such sodium channels are called funny channels. So invert sodium channels generate the term funny currents. And we have the special group of drugs of antiarrhythmics that inhibit such funny channels and thus responsible for antiarrhythmic action. In general, such drugs are called bradycardic drug because slowing of the fourth phase means decreased automaticity of atrial node, and it will be bradycardia. So, about the ion currents in the atrial node. Atrial node is a pacemaker. That's why, in general, no need to speak about zero phase. Atrial node is not responsible for conduction, so it is responsible only for initiation of impulses, for heart rate. That's why it's important to speak about fourth phase of the atrial node, but not zero phase. But in general, during the zero phase of atrial node action potential is the opening of calcium channels, invert of calcium channels, and also during the fourth phase of the atrial node action potential, it is the opening of calcium channels and invert of calcium ions into the cells. So AV node action potential is characterized by the zero phase, rapid depolarization, and during this phase it is the opening of calcium channels plus sodium channels. So both ion currents play the major role in the origin of the zero phase. So if the drugs inhibit sodium channels or calcium channels, such groups of drugs prolong the duration of the zero phase. So also during the fourth phase, calcium and sodium channels play the major roles. So if you want to prolong fourth phase and decrease automaticity of action potential of the AV node, we must use such drugs that inhibit calcium channels or sodium channels. So, and such drugs as sodium channels in antiarrhythmic action, if we are speaking about their action on the AV node, will prolong zero phase, and thus such drugs will decrease conduction of AV node, and plus such drugs as sodium channels prolong the fourth phase. With the red it will be prolongation, and thus they decrease automaticity of AV node. And sodium channel blockers can't play any role on the origin of the atrial node action potential. So almost such drugs have no influence on the action potential of atrial node because major ions that are responsible for automaticity or conduction of atrial nodes are calcium ions. That's why sodium channel blockers can't change the action potential of the atrial node. So, causes of electrical dysfunction in the heart: defects in impulse formation, generation, atrial node automaticity is interrupted or altered, leading to missed beats or ectopic beats, and defects in impulse conduction means that it is the impulse conduction that is altered. So tachyarrhythmias and premature ectopic beats, extra beats, arise because of abnormalities in impulse generation or impulse conduction. So mechanisms commonly associated with defective impulse formation: altered automaticity, triggered activity. So defects in impulse conduction. Altered impulse conduction can result from one or a combination of three mechanisms: re-entry, including accessory tract pathways and conduction block. This is the re-entry type of arrhythmia. On the left, figure A depicts normal impulse conduction, in which an impulse travels synchronously down two parallel pathways, on the left and on the right. Figure B shows a re-entrance electrical circuit, so orthodomic impulse can't go down the right pathway, but the opposite direction impulse travels. So the impulse conducts through pathway 1 and at the junction travels in a retrograde fashion up pathway 2 towards point B. So in re-entry type of arrhythmia, orthodromic impulse can't travel through the conducting tissue, and if we are speaking about retrograde impulse, it travels, and thus to the normal impulse it will be addition of the extra impulse, and this is the origin of arrhythmia. What can we do? We can help to the orthodromic impulse and increased automaticity, but in general, if the drugs increase automaticity, they will cause additional types of arrhythmia. So it's better to decrease conduction in the ischemic area and prevent also the traveling of the retrograde impulse. So to block the traveling of retrograde impulses. So, and the function of the normal impulse, so in the left, will be enough for the conduction in all regions of the conducting tissue of the heart. So basic principles of treatment of arrhythmias. So to treat tachyarrhythmias and extra beats, antiarrhythmic drugs must cause reduction of automaticity in atrial node and AV node, and also such drugs must cause suppression of ectopic foci. The second possible operation is the suppression of pseudo-automaticity or slowing of conduction. So how can the drugs can decrease the conduction. So such drugs can cause the reduction in the conduction of impulses from the atria to the ventricles in supraventricular arrhythmias. And if we are speaking about the treatment of re-entry arrhythmias, slowing of conduction converts a unidirectional block to a bidirectional block. And one more possible type of tachyarrhythmias and extra beats is due to increase of the effective refractory period duration. So bradyarrhythmias and heart block treatment increase of automaticity because such types of arrhythmias are characterized by the decreased conduction in heart block. Or bradyarrhythmias can be the result of the decreased automaticity of the synatrial node. That's why if we are speaking about bradyarrhythmias, it's better to increase the automaticity of synatrial node, for example, or in heart block, we can use the drugs that increase conduction. So, antiarrhythmic drugs are divided into two groups. The drugs which are used to treat tachyarrhythmias and extra beats or premature beats, and the drugs that are used to treat bradyarrhythmias and heart block, according to the titles in the treatment of basic types of arrhythmias. So, classification of antiarrhythmic drugs. According to Vaughan-Williams, international classification. So, A class, very not class, group, very large group A, can be divided into the international 4 realm classes. Later I will show you also 4th group on this diagram. We don't have place. And also 3 subclasses according to the Arabic numbers. So let's start about the drugs which are used to treat tachyarrhythmias and premature beats. Class 1 realm, sodium channel blockers. 1A, quinidine, precainamide, disopyramide. 1B, lidocaine, Mexiletine, phenytoin. Phenytoin drug was discussed in the previous semester. We can use such drug to treat epilepsy or to relieve pain. From today's class, you will know that phenytoin can be also used to treat ventricular arrhythmia. Lidocaine, also the drug that was the effects of which were discussed in the previous semester. It is the local anesthetic. And 1C class, Flecainide, Propafenone, morphine. Class 2nd, according to international classification, beta-adrenoceptor antagonist. I think that these groups of drugs is well known for you. So for non-selective beta-1 and beta-2 adrenal blockers, Propranolol, Dronedarone, and selective, cardioselective, you can also call this group of drugs, beta-1 adrenoceptor antagonist, Metoprolol, Atenolol, bisoprolol, Esmolol, and you see carvedilol we can't put into the selective because carvedilol belong to the drugs that are alpha and beta adrenal blockers. Together with you, I will put here the mechanism of action of such drug. Alpha and beta adrenal blockers. Carvedilol. and calcium class 3, the drugs that increase action potential duration. These drugs can increase the duration of action potential due to the inhibition of potassium channels. That's why such drugs are called potassium channel blockers. Amiodarone, but you see such drug as amiodarone not only blocks third phase and action potential, and that's why it belongs to the potassium channel blockers, but also such drug can inhibit sodium channels and behaves as a 1A class of antiarrhythmic drugs, and also this drug can block fourth type of antiarrhythmic action. It means that this drug inhibits calcium channels, and thus it belongs to the fourth group of antiarrhythmic drugs, calcium channel blockers. So amiodarone belongs to the drugs with a mixed mechanism of antiarrhythmic action. Dronedarone also belong to the third, 1A, and fourth types of antiarrhythmic drugs. So in the third class, dronedarone inhibits potassium channels. In the first stage, it inhibits sodium channels. Second, it means that it inhibits beta adrenal receptors, the same as amiodarone. And fourth class, it means that this drug inhibits calcium channels. So very effective antiarrhythmic drugs. But amiodarone is older drug, so it causes so many adverse effects that nowadays dronedarone was investigated almost the same chemical structure, but without iodide in the chemical structure as in the amiodarone. That's why in general dronedarone is well tolerated. Sotalol, more selective drug, you see it inhibits only potassium channels, third class, and beta adrenal receptors, second class. Antibutylate or fatylite are pure potassium channel blockers, so in the brackets you can put only 3 rows. So class 4, calcium channel blockers, according to the mechanism of their action. Such drugs are verapamil and diltiazem, the drugs from the group of calcium channels with the predominant action on the heart, verapamil, and diltiazem in the middle position between the action on the heart and peripheral blood vessels. Now numbers Arabic. 5 cardiac glycosides for supraventricular tachyarrhythmias. Digoxin can be used. The mechanism of antiarrhythmic action of this group of drugs is the decreased AV conduction. Adenosine also decreases AV conduction. Potassium salts, magnesium salts, such drugs are used for ventricular arrhythmias. And the last group, B, large group, drugs which are used to treat bradyarrhythmias and heart block. Isoproterenol, it increases automaticity due to activation of beta-1 adrenal receptors in the heart and can be used to treat bradyarrhythmias, and atropine due to inhibition of M2 choline receptors in atria and increased automaticity of AV node can be used to treat heart block or AV block. So this table will help you to understand the differences between the different subgroups, subclasses of sodium channel blockers. According to mechanism of action, 1A, 1B, and 1C drugs are all sodium channel blockers. So, we will speak about action potential of purkinje fibers, for example, or AV node. Automaticity is characterized by the duration of fourth phase of action potential. So all of them inhibit sodium channels. That's why they decrease automaticity in AV nodes and purkinje fibers. Conduction. Zero phase of action potential is responsible for conduction. All of them also reduce conduction and prolong zero phase, but more pronounced action is for 1C class. On the second place, 1A group of antiarrhythmic drugs, and 1B class have mild reduction of conduction. Action potential duration is the characteristic that differ the different classes of antiarrhythmic drugs. For example, 1C group don't have any influence on action potential duration. It means that they don't have influence on the third phase. 1A class increase action potential duration, so they inhibit potassium channels that play the major role in the third phase, which is responsible for action potential duration. And if we are speaking about 1B class, such drugs decrease the duration of the third phase of action potential, and thus they reduce the action potential duration. Cardiac contractility. 1B class almost don't have influence on the cardiac contractility. 1C class pronounce action on the cardiac contractility, and 1A also can decrease cardiac contractility. Therapeutic uses. 1A class. Whoa, this is wrong. Can be, it's correct. We will look into the horizontal line, yeah? So 1A class, sodium channel blockers of 1A class can be used according to the site of origin of arrhythmias in atrial or supraventricular arrhythmia treatment and ventricular arrhythmias. 1B class can be used only to treat ventricular arrhythmias. And 1C in theory can be used in both types of arrhythmia, atrial and ventricular, but such group of drugs produce so many adverse effects that it's better to use them only in life-threatening ventricular arrhythmias. So let's speak about class 1 of antiarrhythmic drugs. According to mechanism of action, such drugs are sodium channel blockers. So subdivision of class 1 into the 1A class, 1B and 1C. Quinidine, very popular 1A class antiarrhythmic drug, or procainamide. 1B, I think that you remember that because we have already spoken about such drugs as Lidocaine and Phenytoin in the previous semester. And 1C drugs are unknown for you, Flecainide, Propafenone. So characteristics, class 1 of antiarrhythmic drugs. So the drugs of this class 1 are divided into the 1A and 1B and 1C drugs based upon their potency and effects on conduction velocity. Class 1A drugs decrease conduction and increase refractoriness, third phase, increase duration of the third phase. Class 1B drugs decrease the third phase refractoriness, while class 1C decrease conduction only and don't have influence on the third phase, on the refractoriness. The class 1C drugs are the most potent with the slowest binding and dissociation. Class 1A drugs are the least potent with the fastest binding and dissociation, and class B drugs are moderate in potency. So let's speak about quinidine. The common drug of the 1A subclass of the sodium channel blockers, quinidine. So its antiarrhythmic action. According to mechanism of action of quinidine, it blocks sodium channels, and if you remember, sodium ions play the major role during the 0 phase and the 4th phase. So that's why quinidine affects 0 phase and 4th phase. So it decreases conduction due to inhibition of sodium channels. During the 4th phase, it reduces the duration of it. So quinidine decreases conduction of action potential of purkinje fibers. Also, quinidine blocks sodium channels and prolongs 4th phase, so this drug decreases automaticity of purkinje fibers. And additional mechanism in antiarrhythmic action of quinidine is the inhibition of potassium channels that play major role in the 3rd phase, and 3rd phase is responsible for duration of effective refractory period, ERP. So this drug prolongs 3rd phase because it blocks potassium channels and increases duration of ERP. So the action of quinidine on conducting tissue of the heart. If we are speaking about sinoatrial node, it has the opposite influence on the sinoatrial node automaticity. Due to its direct action, sodium channel blocking effect, it reduces automaticity of sinoatrial node. But also this drug inhibits muscarinic cholineceptors, and if you remember, in the heart RM2 cholineceptors are localized, so it will cause the opposite effect to direct action, increased automaticity. So that's why we can't predict the end effect of this drug on the automaticity of sinoatrial node. In some patients it can be bradycardia, in some tachycardia, but more often mild bradycardia. AV node action. The same opposite directions of influence. If we are speaking about sodium channel blocking, reduces automaticity of AV nodes, and it reduces conduction, increased duration of 3rd phase. And if we are speaking about anti-muscarinic action, inhibition of M2 cholineceptors in the heart, quinidine increases automaticity and conduction, and in general also it will be mild decreased automaticity and conduction of AV node. And in purkinje fibers there are no M2 cholineceptors, the beta 1, and quinidine doesn't affect beta 1, so here will be inhibition of sodium channels in the 4th phase of potential of purkinje fibers. So quinidine reduces automaticity of purkinje fibers. Then quinidine inhibits sodium channels during the 0 phase, so this drug reduces conduction. And also this drug inhibits the potassium channels. That's during the 3rd phase. That's why it increases the duration of effective refractory period. So we can use quinidine to treat re-entry arrhythmia because quinidine will block both directions of the impulses, orthodromic down and anterograde impulse transmission. So that's why this drug converts unidirectional block to bidirectional block. So, and from the left will go to all regions of the conducting tissue of the heart. And on the right here, isoprene beta-2 adrenal blocking drug is used, so this drug increases conduction in the ischemic area and thus helps orthodromic impulse to travel through this ischemic region. So therapeutic uses or indications of quinidine are paroxysmal ventricular and supraventricular tachycardia, sustained and paroxysmal atrial fibrillation, according to site of origin or localization, quinidine can be used in all types of arrhythmia, atrial and ventricular. Route of administration, we use quinidine orally. Adverse effects, reduction in cardiac contractility, lowering of blood pressure. It inhibits alpha-adrenoceptors in blood vessels, that's why it causes reduction of blood pressure. AV block, ventricular tachyarrhythmias, so all the drugs that inhibit potassium channels, special type of arrhythmia, which is called torsade pointes, and quinidine also inhibits potassium, this prolongation of the third phase. So that's why quinidine causes ventricular tachyarrhythmia, special type, torsade pointes. Other side effects synchronism, hearing loss, blurring of vision, dizziness, headache, and disorientation. Nausea, vomiting, diarrhea. In general, this group of adverse effects is called gastrointestinal upset. Hypersensitivity reactions, including thrombocytopenia and rash, belong to the allergic reactions. Next group of antiarrhythmic drugs, also such group of drugs inhibit sodium channels, 1B class, lidocaine, phenytoin. So, such groups of drugs, according to their mechanism of action, block sodium channels. So, they decrease conduction. So first they prolong zero phase and thus they decrease conduction in Purkinje fibers. Due to inhibition of sodium channels, they cause the prolongation responsible for automaticity, so this drug decreases automaticity. And they decrease the duration of effective refractory period. It doesn't mean that they activate potassium channels. But still you must remember the distinguished feature of this class of drugs. So they decrease the duration. So therapeutic uses of lidocaine, ventricular tachyarrhythmias, and premature beats. Lidocaine is devoid of substantial action on the atrial nodes and only slightly inhibits AV nodes. So the general action of the lidocaine, according to localization, is the action in the ventricles. So lidocaine is used principally for ventricular arrhythmias, especially those complicating myocardial infarction. So if we ask you the question, what the drug is a drug of first choice to stop ventricular arrhythmias as a complication of myocardial infarction, you will tell us first choice in such ventricular arrhythmias as the complication of myocardial infarction. The beneficial effects of this drug and the control of this type of arrhythmia may be due to the following. So, lidocaine binds to inactivate when the cells are depolarized. For example, in ischemic area, sodium cells are depolarized and inactivated state, and lidocaine predominantly binds to inactivated sodium channels, the opposite effect of pyridine, for example. So that's why lidocaine can be the drug of first choice in ventricular arrhythmia as a complication characterized by the zone of necrosis and ischemia. Besides that, lidocaine does not reduce cardiac contractility, which is also beneficial effect if used to treat ventricular arrhythmias on the phone of myocardial infarction, because action by itself is characterized by the cardiac contractility reduction. And if we add antiarrhythmic drug with the decreased action on the cardiac contractility, so will help to die.
Professor, we cannot hear you.
So again, I'm with you. It was an interruption in my link. So let's continue with the lecture. Do you hear me now?
Yes, Professor.
Very good. So therapeutic uses of lidocaine. So the beneficial effects of lidocaine in the treatment of the ventricular arrhythmias as the complication of the myocardial infarction is that lidocaine does not reduce cardiac contractility, and also lidocaine does not reduce blood pressure, because in the myocardial infarction it is already decreased blood pressure. And so also, one more third beneficial effect of lidocaine is that its ability to produce AV block is too small, almost no influence on the AV conduction. And these properties of lidocaine is very useful in the class of arrhythmias associated with myocardial infarction. Kinetics of lidocaine make it unsuitable for oral administration. It is given intravenously by infusion to stop ventricular arrhythmias. Adverse effects are moderate inhibition of AV conduction, so that's why we can't use this drug during the AV block of the second degree or third degree. CNS effects such as confusion, dizziness, and tremor. In general, this drug is well tolerated. The 1C class, Flecainide, action of this class on the action potential of the purkinje fibers. This drug also belongs to the drugs that block sodium channels. I will remind you that sodium channels play the major role during the zero phase and fourth phase. So, due to inhibition of sodium channels during the zero phase, flecainide increases duration of zero phase, thus it reduces conduction and excitability of purkinje fibers. And second antiarrhythmic mechanism of action, due to inhibition of sodium channels during the fourth phase, this drug prolongs it and reduces automaticity of purkinje fibers. And if we are speaking about ERP duration, flecainide almost doesn't influence it. So I will remind you that flecainide is used to treat life-threatening ventricular tachyarrhythmias. This drug is very toxic. It causes by itself arrhythmia. I will remind you that all antiarrhythmic drugs possess arrhythmogenic effects, and this arrhythmogenic property is high. So that's why if we use flecainide with a high risk, it can cause arrhythmia by itself. So second class, according to international classification, beta-adrenoceptor antagonists. So non-selective propranolol, it inhibits beta-1 and beta-2. But for us in the treatment of tachyarrhythmia and premature beats, it is more important to inhibit only beta-1 in the heart, because due to the action on beta-1 adrenoceptors in the heart, such drugs produce antiarrhythmic effects. So that's why cardioselective drugs is better to use in this type of disorders. Metoprolol, Atenolol, bisoprolol, Esmolol. And also carvedilol, the drug that inhibits beta-1, beta-2, and alpha-1 adrenoceptors, also can be used. So mechanism of antiarrhythmic action of beta-adrenoblockers. These drugs increase, without the influence of the drugs, increased sympathetic innervation, provides increased automaticity of atrial node, increased automaticity of the AV node, and conduction of AV node, and also increased sympathetic zone provides increased automaticity of Purkinje fibers. So all these parameters will be reduced with the administration of beta blockers. So antiarrhythmic action of beta blockers in the treatment of arrhythmias is the reduction of automaticity of atrial node, reduction of automaticity and conduction of AV node, and decreased automaticity of Purkinje fibers. So beta-1 adrenoceptors are localized almost in all sites of the heart, in the atrial node, in the AV node, and also in the typical cardiomyocytes of the ventricles when the adrenoceptors, beta-1 adrenoceptors are blocked. So conduction, automaticity, excitability of conducting tissue will be decreased, and ERP duration will be increased in all parts of the heart. In this regard, beta blockers are effective for both types of arrhythmias, ventricular and supraventricular. As antiarrhythmic agents, cardioselective beta-1 adrenal blockers, Atenolol and Metoprolol, and also non-selective beta-1 and beta-2 blockers, Propranolol, are used. So all types. It was a fact, but the adverse effects are more severe and more pronounced will be with the usage of non-selective beta-1 and beta-2 adrenal blockers. So we can divide adverse effects of propranolol into two groups. One group of adverse effects due to inhibition of beta-1 adrenoceptors, and second group due to inhibition of beta-2. So if we are speaking about beta-1 receptor inhibition, so such adverse effects all will be due to the action of propranolol on the heart. AV block, reduction of myocardial contractility, bradycardia. Adverse effects due to inhibition of beta-2 adrenoceptors, bronchospasm, cold extremities due to vasoconstriction, hypoglycemia. So here I put the most important adverse effects: spasm of bronchi and peripheral vessels. Because of such adverse effects, selective beta-1 adrenoceptor antagonists were investigated. So third class of antiarrhythmic drugs, drugs that increase action potential duration. According to mechanism of action, such drugs are potassium channel blockers. Of course, we have pure potassium channel blockers, such drugs as ibutylide and octreotide. They selectively inhibit potassium channels. But also we have other drugs which are not selective with a mixed mechanism of antiarrhythmic action. For example, Amiodarone, the drug that inhibits third class, belong to the third class, first A class, second class, and fourth class of antiarrhythmic drugs. So these drugs inhibit potassium channels, sodium channels, beta adrenoceptors, and calcium channels. The same concerning Dronedarone. Sotalol is more selective. It blocks potassium channels, plus it inhibits beta adrenoceptors. So general characteristics of the third class of antiarrhythmic drugs. These drugs block potassium channels, and thus they diminish the outward potassium current, which leads to repolarization of the cardiac cells. So these drugs of antiarrhythmics prolong repolarization phase 3 and therefore increase action potential duration and also increase duration of effective refractory period. This is antiarrhythmic action. The same you can see on the Purkinje fibers. Inhibition of the potassium channels during the third phase prolongs its duration, and it will be increased effective refractory period duration. But if we are speaking about Amiodarone's action, these drugs also inhibit beta-1 adrenoceptors, sodium channel, Also, these drugs inhibit calcium channel. That's why this drug increases duration of zero phase and prolong this phase, so it decreases conduction and excitability of purkinje fibers, and also decreased automaticity of atrial node, and also decreased automaticity and conduction of AV node. And also this drug, due to inhibition of sodium channels, calcium channels, beta-1 adrenoceptors, prolonged fourth phase, which is responsible for automaticity. So amiodarone decreases automaticity of purkinje fibers. And also it decreases automaticity of the atrial node and AV node. So on this slide you can see the chemical structure of the amiodarone. According to mechanism of action, it belongs to the potassium channel blockers, sodium channel blockers, beta-1 adrenoceptor inhibition, and calcium channel blockers. So the main action due to inhibition of potassium channels is the prolongation of the third phase, rapid repolarization in different parts of conducting tissue. So amiodarone prolongs effective refractory period both in the conducting tissue and also in the cardiomyocytes. Besides that, amiodarone exerts some inhibiting action on the sodium channels and calcium channels, so it causes blockade of corresponding currents in the zero and fourth phase. So it also causes non-competitive block of beta adrenoceptors. Therefore, it has complex effects showing not only class 3 action of antiarrhythmic drugs, but also class 1A, second and fourth actions class. So, and these drugs, because of its multiply mechanism of action, also can cause wide range of adverse effects: bradycardia and reduction in cardiac contractility, slowing of AV conduction. In some situations, it can cause AV block, hypotension. So it is due, for example, to inhibition of alpha adrenoceptors, also due to inhibition of calcium channels, induction of ventricular dysrhythmia, especially type torsades de pointes. It is due to prolongation of the third phase, rapid repolarization. And it causes the increased duration of the third phase because it inhibits potassium channels. Tremor, ataxia, neuropathy, muscle weakness. Hyper or hypothyroidism, because amiodarone contains iodine in its structure. Pneumonitis leading to interstitial pulmonary fibrosis. This fibrosis may be lethal, and also it causes hepatitis. Corneal microdeposits of drug, iodine accumulation in the skin, which causes blue skin discoloration. It can be blue or blue together with the gray color. Photosensitivity reactions, and because of many serious adverse effects, this drug is not recommended for long-term treatment. But according to wide range of antiarrhythmic action, this drug is very effective antiarrhythmic drug. Torsades de pointes arrhythmia. You can see the record of this type of arrhythmia on the EEG. So here on the left and on the right you can see polymorphic ventricular tachycardia. It is characterized by the influx of calcium, not according to its normal time. So it is the opening of calcium channels during the third phase. So third phase is not finished, and it is the influx of calcium ions, and thus this invert of calcium provides generation of the new action potential. So next drug, Dronedarone. It is a structural analog of amiodarone, but in which, in the dronedarone, the iodine atoms have been removed from the phenyl ring, and a methane sulfonyl group has been added to the benzofuran ring. So dronedarone lacks the iodine in its chemical structure. The design was intended to eliminate action of the parent drug on thyroxine metabolism and to modify the half-life of the drug. So no thyroid dysfunction or pulmonary toxicity has been reported in the short-term studies. So dronedarone is better tolerated versus amiodarone. However, liver toxicity, including 2 severe cases requiring liver transplantation, has been reported. So, hepatotoxicity effect is not disappeared. Like amiodarone, dronedarone has multi-channel actions according to antiarrhythmic mechanism of action. So this drug also inhibits potassium channels, calcium channels, sodium channels. So this drug also can be used in atrial arrhythmias, in ventricular arrhythmias, according to localization. Also, these drugs inhibit beta adrenoceptors, and we use this drug twice daily. Next group of drugs, calcium channel blockers, verapamil, diltiazem. Action of verapamil on the sinoatrial node. I will remind you that calcium ions play the major role in the action potential of the sinoatrial node and AV node. And if we are speaking about purkinje fibers action potential, only calcium ions play the major role during the plateau. In the zero phase, it is sodium inwards ions during the fourth phase, also inwards of sodium in the action potential of purkinje fibers. That's why verapamil can't be used to treat ventricular arrhythmias. So verapamil can be used to treat supraventricular or atrial arrhythmias. So mechanism of antiarrhythmic action. Verapamil inhibits calcium channels during the fourth phase, so this drug decreases automaticity of the sinoatrial nerve. Of course, you can see that it prolongs zero phase, but it is the pacemaker sinoatrial nerve. That's why no need to speak about the conduction. So, but in AV node, we can speak about conduction. It can be pacemaker only when the sinoatrial node doesn't work. So, due to inhibition of calcium channels in the zero phase, verapamil prolongs it and decreases conduction. Red line. And also due to inhibition of calcium channels in the fourth phase, it prolongs it, and thus it decreases automaticity of the AV node. So antiarrhythmic action of verapamil on the AV node is the decreased conduction and automaticity of the AV node. And again, I will remind you that verapamil can inhibit only calcium channels. That's why in the purkinje fibers it can cause only prolongation of the second phase, but in general, nothing will be changed in the antiarrhythmic action. That's why verapamil can't be used in the treatment of ventricular arrhythmias. So verapamil blocks both activated and inactivated L-type calcium channels. Thus, its effect is more marked in tissues that fire frequently, those that are less completely polarized at rest, and those in which activation depends exclusively on the calcium current, such as the sinoatrial and AV nodes. AV nodal conduction time and effective refractory period are consistently prolonged by therapeutic concentrations. So verapamil usually slows the atrial by its direction, by direct action. It inhibits calcium channels, but its hypotensive action may occasionally result in a small reflex increase of SA rate. So that's why verapamil can't cause pronounced bradycardia. Verapamil can suppress both early and delayed after depolarizations and may abolish low responses arising in severely depolarized tissue. So therapeutic uses of calcium channel blockers. Treatment of re-entry arrhythmia, re-entry and supraventricular tachycardia. It is called atrial flutter, atrial fibrillation. You see now treatment of ventricular arrhythmias and the spectrum of therapeutic uses of calcium channel blockers. And adverse effects, bradycardia, hypotension, peripheral edema. It is the result of the decreased perfusion due to vasodilation in the kidney, so secondary activation of renin-angiotensin-aldosterone system. Aldosterone provides sodium and water retention, that's why peripheral edema develops. Magnesium sulfate on this diagram, you can see the chemical structure. According to its antiarrhythmic action, this drug slows the rate of atrial node impulse formation, and also it prolongs conduction time along the myocardial tissue. I will remind you that in general, magnesium ions are antagonists of calcium ions. So therapeutic uses of magnesium sulfate. I will remind you again that magnesium sulfate can be used to relax smooth muscle cells of myometrium. This drug can be used as a laxative, and also this drug can be used as antiarrhythmics. According to localization to treat ventricular tachyarrhythmias, torsades de pointes, digoxin-induced arrhythmias. Digoxin will be discussed later when we will speak about the treatment of heart failure, acute and chronic. So digoxin is the drugs which are used to treat heart failure, can cause by themselves special types of arrhythmia, extrasystole. So that's why we must use some antiarrhythmics for correction of digoxin-induced arrhythmias. But let's speak about adverse effects of magnesium sulfate. Don't forget that magnesium sulfate is a drug of first choice in torsades de pointes arrhythmia. General adverse effects, decrease of contractility and heart rate. I will remind you that magnesium is the antagonist of calcium ions, that's why it causes the decreased contractility and heart rate. Calcium by itself increased cardiac contractility and influx of calcium during the fourth phase of action potential of atrial node provides tachycardia. So magnesium sulfate is an antagonist, so that's why it will be decreased heart rate, decreased AV conduction, decreased blood pressure, headache, flushing, constipation. These effects also is due to vasodilation of cerebral blood vessels, headache and flushing, and constipation is due to deficiency of calcium in the intestinal walls. Instead of calcium, it will be magnesium. That's why it will be decreased motility of the intestine, and this provides constipation. Next group of antiarrhythmic drugs, cardioglycosides. In the previous 2 centuries or 3 centuries, I think 2 centuries, digoxin was used to treat heart failure, but more earlier than 2 centuries ago, digoxin was used as the drug that stimulates diuresis, and people think that with the increased diuresis, all bad or black substances will go out from the body, and such that substances may be the cause of the different illnesses. That's why to treat different disorders, the drugs that eliminate different fluids from the body, such as the drug that stimulates sweating, diuresis, salivation, were used to treat different disorders. And after this, only scientific method was developed, and for example, cardioglycosides were used not to stimulate vomiting, for example, and diuresis, but to increase cardiac contractility, and that's why it was used to treat heart failure. But nowadays, instead of the treatment of heart failure, because in the treatment of heart failure it's better to use the drugs that decrease afterload and preload, so the drug that cause blood vessel relaxation is better to use. So digoxin, the example of cardioglycosides, can be used to treat arrhythmias, but not heart failure. So digoxin mechanism of antiarrhythmic action is characterized by the activation of reflex activation of nervus vagus as the result of increased cardiac contractility. So nervus vagus action on the AV node is a decreased AV conduction. So mechanism of the antiarrhythmic action of digoxin is the decreased AV conduction. So we use digoxin in the treatment of tachyarrhythmic type of atrial flutter when many impulses will go to the ventricles from the atrial. And conversion of this tachyarrhythmic type of atrial flutter to normosystolic type of atrial flutter when it will be rapid contractions of atria but still normal frequency of contraction of ventricles. So no marked hemodynamic changes will be in this type of contraction of the heart. But still, because of the rapid contractions of the atria, here will be the special conditions to form thrombosis, clots. That's why, together with digoxin, we can use anti-clotting drugs, anticoagulants. So digoxin diminishes conduction velocity in the AV node. This is the antiarrhythmic mechanism of action. This drug is used to control ventricular response rate in atrial fibrillation and flutter. At toxic concentrations, digoxin causes ectopic ventricular beats that may result in ventricular tachycardia and fibrillation. And digoxin can be used to treat heart failure, and in the treatment of heart failure, digoxin by itself causes ventricular ectopic beats, and phenytoin will be the drug of first choice. I will show you this phenytoin. It was discussed earlier. It belongs to the sodium channel blockers, 1B class. This is 1A. Here you can see that phenytoin belongs to 1B class of antiarrhythmics, so phenytoin will be the drug of first choice to treat, or it's better to say, to reverse, to stop ventricular extrasystoles caused by cardioglycosides, digoxin, for example, administration, when it was used to treat heart failure. And now let's return to this slide. Do you see digoxin on your slide? Do you see?
Yes, Professor.
Okay, good. So at toxic concentrations, digoxin causes ectopic ventricular beats that may result in ventricular tachycardia and fibrillation. So in order to stop these ventricular beats, we can use phenytoin as antiarrhythmic drug of first choice against digoxin ventricular type of arrhythmias. Next drug, antiarrhythmic, adenosine. Mechanism of antiarrhythmic action. It stimulates A1 receptors. I will remind you that A1 was discussed in the bronchial asthma. A1 receptors are localized in the smooth muscle cells of bronchi, and the activation of these receptors provides bronchoconstriction. So when we use adenosine, as a side effect, adenosine causes bronchospasm. So that's why we can't use adenosine as antiarrhythmic in patients with bronchial asthma. A2 adenosine receptors were localized in platelets, and stimulation of such receptors in platelets by adenosine provides antiplatelet effect. This is beneficial if the patient has, for example, arrhythmias. Okay, so let's speak about antiarrhythmic action mechanism of adenosine. This drug stimulates A1 receptors in the heart and causes reduction of AV conduction and also prolongation of effective refractory period. Adenosine is used intravenously to terminate supraventricular tachycardia and has largely replaced verapamil and digoxin in this purpose because of its much safety and short-lasting effect. I will tell you that intravenous bolus dose of adenosine lasts only 20 to 30 seconds. That's why during this time side effects are not very long. Reduction in cardiac contractility, vasodilation, bronchoconstriction, and chest pain lasts only 20 to 30 minutes. That's why nowadays it's better to use adenosine to terminate supraventricular tachycardia. Not verapamil, not digoxin. These drugs have long onset of action, so it's better to use adenosine instead of verapamil and digoxin. To treat supraventricular tachycardia or flutter, supraventricular flutter. So this is the action of ivabradine, antiarrhythmic action of ivabradine. So it belongs to the group of bradycardic drug. It affects fourth phase of action potential of the sinoatrial node. The mechanism of its action is the inhibition of funny channels. These channels work during the fourth phase of sinoatrial node. So, and the current through these funny channels provides rate of spontaneous diastolic depolarization. This phase, fourth phase. And you see fourth phase determine automaticity of sinoatrial node and also determine heart rate. So rapid onset of the fourth phase provides generation of the new action potential, and it will be increased heart rate. When we use ivabradine, it inhibits the function of funny channels when it is the influx inward of sodium ions and outflux of potassium. So that's why it slows the onset of the fourth phase, so it causes the reduction of heart rate. That's why we call this drug as bradycardic drug, because it inhibits the funny channels, or it's better to say that it inhibits the current through funny channels. So mechanism of antiarrhythmic action of ivabradine, it selectively inhibits the pacemaker IF current in a dose-dependent manner. Blocking this channel reduces cardiac pacemaker activity. So these drugs selectively slowing the heart rate and allowing more time for blood to flow to the myocardium. Therapeutic uses. It can be used in today's lecture to treat supraventricular tachycardia, inappropriate sinus tachycardia, for example. Also, it was discussed in the anti-anginal drugs. It can be used to treat chronic stable angina. And also we will discuss the treatment of chronic heart failure later, and also we'll see again evaporating. Reverse effects. Luminous phenomena by patients described as sensations of enhanced brightness in a fully maintained visual field. It is a phenomenon characterized by the experience of seeing light without light actually entering the eye. Then bradycardia, it is the resultant effect of its mechanism of action, and headaches, AV block, ventricular extrasystoles, dizziness, and blurred vision. So that's all for today's class.